Hey everybody, welcome back to the ECG channel. My name is Reed, and don't forget that you can download the PDF down in the description below to follow along with today's rhythm. And feel free to like this video and subscribe to the channel if you enjoy. So let's jump into it. So the first thing we're going to do is we're going to look at the force and understand what's going on with this ECG. And so maybe I'll come down here to lead 2. We're going to say I've got this narrow complex rhythm that seems to be pretty regular, and you see it stays that way the entire time. When it's a narrow complex rhythm, it makes me think that conduction is from my AV node down my His-Purkinje fibers through those rapidly conducting fibers to the ventricles, which makes my QRS narrow. And I've got P waves that seem to be going on in front of my QRS complexes, which is reassuring. To find the rate, I'll find a QRS that lands somewhat on a solid line. Maybe we'll pick this one. We'll say 300, 150, 100, 75, 60. That would be 50, so maybe 55 beats per minute. So we've got just a mild bradycardia. But we see some sinus P waves in front of those QRS complexes, so we suspect a sinus bradycardia. And let's evaluate the atria. So those P waves are upright in lead 1, and they're upright in AVF. So this is a sinus bradycardia, right, at 55 beats per minute. The next thing in our conduction system is going to be our AV node, and we know the AV node is represented by the PR interval. And so if I measure my PR interval, if I come here, you can see my P wave begins here, QRS begins here. So I would say that's like, what, 4 little boxes. So my PR interval is 160 milliseconds, which is in between 120 and 200 milliseconds, right? Write that again, milliseconds, which is normal. And now I just need to make sure that every P wave has a QRS and that the PR intervals stay the same. And so I scan through here, and I see that that seems to be the case, right? And then I also look and just make sure that there are no extra P waves, right? Make sure there's no extra P waves hiding around, and there's not. So a good AV node function. Next thing we're going to go and look at is the QRS complex. My QRS is narrow, so the duration of my QRS here, my QRS is less than 120 milliseconds, and so it's a nice narrow complex rhythm. The axis of my QRS is upright in lead 1, and it's upright in AVF. That tells me that my axis is going down to the left, and that's normal. And you can see our wave progression. We've got a little kind of slow start, but V3 seems to be nice and upright. So does V4. So some funky R wave progression. We'll look at that later. When I evaluate my QT interval, I like to just make sure that if I look in between two QRS complexes, that by the midpoint we have our T wave has terminated by then. Okay. So the last thing we do is we look for pathological Q waves, and we look for ST and T wave changes throughout the rhythm. And these are ST elevations and depressions that tell us more about the acute event of ischemia or infarction versus pathological Q waves, which tells us if there's been some damage previously to the myocardium. And so first thing I see kind of that really jumps out at me is some ST segment elevations that are really in these anterior leads predominantly, but maybe a little bit in the septal leads, right? So if you look at the anterior leads, we've got V3, ST elevation, V2, to a lesser degree, V4, and to a much lesser degree, V5, but we even got some septal ST segment elevation. So I would say the predominant ST segment elevation here would be in like an anteroseptal pattern. So anteroseptal ST elevation. So then your eyes need to go to the limb leads and see, is there any reciprocal depression? And there is. If you look here, lead 2, there's some ST depression. Lead 3, there's some ST depression. AVF, there's some ST depression, right? And so we've got reciprocal ST depression in those leads. And you can see too, it seems like there's even maybe just a hair of hyperintense T waves in AVL, but really nothing that's kind of jumping out at me. And so let's just recount that V1 and V2 are septal leads. V3 and V4 are anterior leads, right? And so that's why we kind of call this maybe an anteroseptal elevation. And this reciprocal depression kind of helps kind of solidify maybe why we had these anteroseptal changes, right? It makes it more likely this is a myocardial infarction. And so when we put this all together, what do we get? We get a sinus bradycardia at 55 beats per minute. We have anteroseptal ST elevation with reciprocal ST depression in the inferior leads. And so this patient was taken to the cath lab, and they were diagnosed with an occlusion of the left anterior descending artery. And we know that the left anterior descending supplies kind of the anteroseptal region. It supplies the septum, and it supplies kind of the anterior wall of the left ventricle. So that all makes sense. Well, if you have any questions about this rhythm, feel free to let me know. And if not, thanks so much for watching. We'll see you on the next ECG video, and hope you have a great rest of your day. Take care.